So, good afternoon to everyone joining us from across the world. We've got just under 1,000 people registered from across the world watching some of these webinars for European Public Health Week. This has been organised, these live webinars, between the European Public Health Association, specifically the Urban Public Health section, and the University of Manchester. There are a great range of talks across the whole week that we've organised for you with some of our colleagues from across the world. We would just like to say that, sorry about that, I've just got to quickly take that off as I am live so I can hear you as well. Sorry about that, bit of a mistake, but that brings into a point that this is learning for us, and as we're all in this new situation where we are across the world and all working from home, there might be some teething issues about the technology, so we apologise in advance about that. Across the day, we'd like you to join in by tweeting some questions. If you could use the hashtag AskPH, or you can tweet, put some comments in the YouTube for your questions, or you can email much@manchester.ac.uk. And after each talk, I will ask some of the questions that have come up throughout the talks. So without further ado, first up today, we've got a presentation on violence against women from Professor Cathy Vaughan, who's the director of the World Health Organization Collaborating Centre for Women's Health at the University of Melbourne.
Thanks, Greg. I'm just bringing the shared screen up. Is that working now?
Yeah, that's correct.
Fantastic. Thank you very much. And for me, it's good evening, everyone. Good morning, depending on where you are in the world. And because it is good evening, I apologise in advance if small children come bursting in at some stage wanting bedtime things, but hopefully they'll stay on their side of the fence for the duration. Greg asked me to speak today about violence against women, and I'm very grateful for the opportunity to speak to colleagues in the European Public Health Association and to bring the issue of violence against women onto the agenda when you're talking about sustainable development goals and healthy cities. So it's really lovely to be here. So thank you, Greg. By way of starting, just because I know that many people who work in urban health may not really have had much experience in the area of violence against women, I thought I'd start by defining what we mean by violence against women. And really, most people still draw on the 1993 UN Declaration on the Elimination of Violence Against Women, which highlights that violence against women is any act of gender-based violence that results in or is likely to result in physical, sexual or psychological harm or suffering to women. And that includes threats of such acts, coercion or deprivations of liberty. And importantly, it includes both public and private acts of violence against women. It's a really highly prevalent experience, and usually when I'm doing a talk like this, including today, I do want to acknowledge that I realise this is something that will have affected people who are listening, whether that's women who've experienced violence themselves, or anyone who's listening who may have experienced this as a child, or you'll have friends and family who've experienced violence throughout their lives. And I hope that the way I speak about violence today is respectful of that really difficult experience. It is a highly prevalent experience, and the statistics that's usually used is 1 in 3. So globally, if you look at the outcomes of the WHO multi-country study, which the initial study was done in 11 countries and then has been replicated in many other countries around the world, on average, around 1 in 3 women have or will experience an act of violence at some stage during their lives. In my own country, in Australia, and this is true in many other parts of the world, it's the leading cause of death and disability for women of reproductive age. As women age, obviously, in later life, other causes of death become more common, but it is a really important cause of death and disability for women across the globe. And violence undermines the achievement of all Sustainable Development Goals. So it is a big part of the focus of Sustainable Development Goal 5, but all of the other Sustainable Development Goals will be undermined while women are still experiencing violence in their daily lives. So when we're talking about Sustainable Development Goals, just to highlight for people that SDG 5 is around achieving gender equality and empowerment of all women and girls. And one of the specific targets for SDG 5 is to eliminate all forms of violence against women and girls in both public and private, and that includes trafficking and sexual and other types of exploitation. The two indicators for this target specifically look at two types of violence. And the reason they've been chosen as indicators is because we've got the best developed tools to measure these forms of violence compared to the other types of violence that women may experience in their lives. So the first one focuses on intimate partner violence, and that includes physical, sexual, or psychological violence by a current or former intimate partner. And the second indicator focuses on non-partner sexual violence, so sexual violence that has been perpetrated by someone other than an intimate partner. And so that could be sexual violence or rape that occurs in a public setting, but also that may occur in private. Violence against women also is particularly relevant for other SDGs. So that could include SDG 11.7, which is safe public spaces, but also it includes a number of other SDGs as shown there on the screen. Oops, no, okay. So in thinking about researching violence against women, so obviously to collect data against those two indicators involves conducting research, and in particular prevalence studies, national prevalence studies, which are not easy things to undertake. And we've seen over the last few years, since countries have signed on to the Sustainable Development Goals, an explosion of interest in measuring violence against women, and yet very limited capacity, particularly in some of the low and middle income countries, to safely and ethically measure violence against women. So that's one of the things I want to speak a little bit more about now. When you're doing research on violence against women, it's obviously a very sensitive topic and can be quite a distressing thing for women to talk about their experiences of violence. It can stir up past trauma and re-trigger that past trauma. And it can also cause immediate safety risks for women. So if women are currently living with violence and tell researchers about that and talk about their experience, and the person who's using violence against them becomes aware of this, obviously that is a huge safety risk for that woman and potentially her children and extended family. So there are very specific ethical considerations when you're doing prevalence research on violence against women, or any form of research on violence against women, that wouldn't be the case for research on other public health issues. Prevalence studies around diabetes and ischemic heart disease, for example, don't have the same level of safety and ethical concerns as research on violence against women does. So over the years, and in particular here, full credit to WHO, who've developed guidelines and a whole range of resources on safe and ethical research on violence against women. And there are a number of principles that they highlight. Firstly, that the safety of participants and of the research team requires considerable training of the researchers. It's not a matter of just going through the questionnaire with a research team. It's really because most violence against women, not all, but most prevalence studies are done through face-to-face interviews. And so training of a research team about some of the scenarios that might come up during completion of a face-to-face questionnaire around violence, and how to handle things like participant distress, children coming into the room, an angry husband coming home, and wondering why she's talking to some stranger about her private life. A whole range of things that might put either the participant or the research team at risk that requires considerable planning. And included in that planning is thinking about confidentiality. So in many other forms of research, you might advertise a study widely to try and increase response rate, or to get community acceptance of a study that you might be doing where it's a household survey involving face-to-face questionnaires. But in this instance, you don't want to advertise that the topic of a face-to-face questionnaire is violence, in case that inhibits some women being able to participate or causes risks within a household if it becomes known that one of the women in the household has responded to a questionnaire and everyone else in the household knows what that was about. There are other things to consider as well in terms of taking action to reduce participant distress at the time, but also ensuring that referral pathways are developed and planned for, so that if a woman discloses violence, and it may be for the first time that she has disclosed violence to anyone, that there's options for her. She may not want to do anything about it, and it may be historical violence, but even if it's current violence, it doesn't necessarily mean that she wants to pursue seeking services or law and justice interventions, but she does need to be left knowing her options by the researcher, and that's part of the responsibility of the research team in doing this research. As someone who leads researchers, teams of researchers doing this kind of work, it's also really important to take responsibility for debriefing and providing ongoing support to the research team who can be subject to vicarious trauma from doing this kind of work. And because women do take a risk when they share their stories, and their stories are painful when they're talking about experiences of violence, there's a real obligation that the studies we do are methodologically sound, properly interpreted, and are used to create change. And so one of the things that I'm involved in at the moment is the Novor Data Initiative, which is led by the UNFPA Asia Pacific Regional Office and has been funded by DFAT, the Department of Foreign Affairs and Trade from Australia, to try and build capacity in Asia and the Pacific to undertake safe, ethical and rigorous research on violence against women. As part of that program, the University of Melbourne has partnered with UNFPA and with Australia's National Research Organisation for Women's Safety to develop and pilot and now run for several years now a 4-week face-to-face intensive training to try and build capacity of national statistics officers, national women's machineries, organisations who are involved in research on violence against women in a range of countries in Asia and the Pacific. And just moving my slides. One of the things that we focus on in that training is on data literacy, as well as how to do the research safely and effectively, and lots of role playing. We also talk a lot about how to use and interpret data and how to use that in creating effective change. So one of the things that we might look at is a bunch of statistics here. I'm showing this map of the Asia Pacific region with all of the studies that have been done over the last 20 years in that region. So you can see that many of the countries have actually undertaken prevalence studies in at least one of the provinces of the country, if not the whole country. The beige larger balls, usually around the outside, that are the lighter brown colour, are the lifetime prevalence of violence. So that's the proportion of women who report that they have experienced either intimate partner or sexual violence from a non-partner over the course of, sorry, actually this is just for intimate partner violence, who have experienced intimate partner violence over the course of their lifetime. The orange balls in the centre are for those women who have disclosed that they're experiencing intimate partner violence over the last 12 months. So the outside balls are lifetime, and the inside is really current when you're thinking about last 12 months. And we use this kind of data to try and support participants in the course to think about differences and similarities across countries. So for example, if we look at Afghanistan, where the red circle's just gone up the top, you can see that when the most recent prevalence study was undertaken in Afghanistan, 51% of women reported that they'd had experienced intimate partner violence at some point in their lifetime. And 46% of women said that they had experienced it in the last 12 months. You could compare that to a country like the Marshall Islands, a very small country in the Northern Pacific, where 51% of women also reported that they had experienced violence in their lifetimes, but only 18%, well, only, it's still quite a large number, 18% of women reported having experienced intimate partner violence in the previous 12 months. So we work with participants to think about, well, what's going on in Afghanistan compared to the Marshall Islands, of same lifetime prevalence in the two countries. But what you can see is that in Afghanistan, once a woman has started experiencing violence, the sort of options or opportunities for her to leave that relationship and to escape the violence are very, very small. So most women, once violence has begun in a marriage, and it is usually a marriage in the context of Afghanistan, then they're stuck with that. There are very few options for them to leave a relationship, and there are very few services as compared to a country like Marshall Islands. Similarly, we might look at a lower prevalence country like Myanmar and compare that to Nepal, where in the last 12 months, both countries had an 11% prevalence rate over the last 12 months, but more women over the course of their lifetime had reported violence in Nepal. And then it would be important to look at the trends over time. Is this because things are getting better in Nepal, where there is increasing recognition of violence, there is increasing options for women. There are more services available. The legal protections for women are better than they may have been, say, in past decades. Staying with Nepal, where you've got a 25% lifetime prevalence rate, that is the same actually as Australia, where I'm speaking to you from tonight. So in both countries, 1/4 of women report that they've experienced intimate partner violence at some point in their life. But in Australia, only 1% of women currently report violence in their relationship. Now, working in the sector, I'd say that's definitely an underreport, but even so, all of these figures will be an underreport. Even so, there's clearly more options and services and opportunities for women to seek help in Australia as compared to Nepal. So that's the kind of exercise that we would do in that course, to try and build the capacity of participants to look beyond just the raw numbers and try and interpret them and understand what those numbers mean, and then use them for creating change in their own countries. And there's some great examples from Asia and the Pacific of people using research on violence against women to advocate for more funding for services and to really inform the design of their services. And I'm thinking particularly of countries like Vietnam, who've done repeated surveys now over time and really have used those to change the way the sector responds to violence against women. So measuring SDGs and the indicators is really important, but it's not everything. And there are things that missed if there's only a focus on measuring the SDG indicators. So some of the obvious things about what's missed are different forms of intimate partner violence. So if you remember back to the earlier slide, there was focus, when you think about intimate partner violence, it spoke about physical violence, sexual violence, and psychological violence. The behaviours that are recorded for physical and sexual violence are quite clear. For psychological violence, there's perhaps less consensus across countries as to how you might measure psychological violence. And then for other forms of intimate partner violence, controlling behaviour, coercion, financial violence, there's even less agreement, and we don't have good tools for measuring those. And so they're not included in the indicator, but it doesn't make them any less important as really very difficult experiences for women to have that have a huge range of long-term impacts on mental and physical health and social and economic rights. So we miss some forms of intimate partner violence. We also miss non-sexual violence by other family members, carers and other members of the public. So you remember that the other indicator, the second indicator, focused on non-partner sexual violence, but that doesn't capture non-partner physical violence or emotional psychological violence that might be perpetrated against women by family members, that's parents or siblings, by their carers, and by other members of their community. And I'm actually a qualitative researcher, despite having just spoken to you about prevalence research. And most of my research is with groups who are often missed out in a focus on SDG indicators. So I work in Australia largely with migrant and refugee women and women with disability, as I do in other parts of the Asia and Pacific region. And so the specific types of violence that migrant women, for example, might experience are not measured in these indicators. And there are particular forms of violence that particularly migrant women, perhaps more so than refugee women, but migrant women might experience that non-migrant women don't. So in Australia, that could be things like having your passports and all your immigration documents destroyed, or men who sponsor a woman out on a particular type of visa and then threaten to cancel that visa and have her deported to another country, or to take her children to another country, or have her deported without her children. So a lot of threats and controlling behaviours that are directly related to a woman's migration status. Women with disability experience particular forms of violence that other women don't experience. That could be things like destruction of assistive devices. It can be over-medication or under-medication. It can be neglect, being left without access to mobility equipment and also without access to food and water in some instances. So really, forms of violence that are at that intersection of gender-based violence, but also violence associated with, in the case of women with disability, of ableism, but it might also be at the intersection of forms of violence associated with racism or homophobia, ageism, if you're thinking about elder abuse, colonisation, the levels of violence against Indigenous women in Australia are substantially higher than they are against non-Indigenous women. The violence that occurs against women in conflict settings, a whole range of other factors. So SDG indicators really important, but they don't capture all of the forms of violence that women experience, and they particularly are not sensitive enough to capture the specific forms of violence that some women will experience. And they don't capture state perpetrated or state sanctioned violence, and certainly working with migrant and refugee women, that's something that's always very at the forefront of my mind. So it can mean that the experiences of particular groups of people are invisible in the data that we collect, but also therefore in the responses that we design. And the meanings that women attach to their experience and the contexts in which it occurs aren't captured. And this is really important at the moment when we're thinking about the impact of COVID-19 and the rest of this panel talking about safer cities. People being asked to shelter in place or to stay at home at the moment. Home's not safe for many women, and we know globally we're seeing an increase in help seeking from women who are being sort of isolated in place with a violent partner, and the impact of the social isolation measures that are being taken in response to COVID-19 for women who are living with violence. I just thought, I'll go back, just being a qualitative researcher and knowing that the experiences of particular groups are sometimes invisible and that meanings and contexts aren't always captured, I just thought I'd share some work that we've done with migrant and refugee women in Australia and some work with women with disability in the Philippines about alternative methods of showing their experiences of violence. I worked with a group of migrant and refugee women in Victoria, in Melbourne, in Australia, and actually we also had some participants come up from Tasmania, and these were women who had direct experience of violence or who were advocates in their migrant or refugee communities in relation to violence. And they used photo voice, so taking photographs and writing captions to share what they wanted to say to their community or to the general public about their experience of violence. And what they wanted to talk about was often quite different than the data that we would have got in response to our question guides and the interviews and focus groups that we ran. And they were certainly quite different messages than you would be able to get from a prevalence study. So Kelly here has taken a photograph of the public housing where she used to live when she was experiencing a lot of violence. And I really like this photograph. She went back to take photos at the place where she was living when she was in an extremely violent relationship. And in fact, found when she got there that she became quite distressed, had a panic attack. And so the photo is quite blurry, and she deliberately wanted it included in a big exhibition we had of their images, because she said that the blurriness represents how she felt going back. And she says that it's hard realising it's been so many years, but the feelings are still there. Kelly was subject to, she'd left that violent relationship more than 10 years prior to this photo being taken. And I think it is a really good illustration of the long-term mental health impacts of violence on women and their children. This is another one of Kelly's photos. She was a fantastic photographer. In this photograph, she just took a photo on her phone and then used a filter to Photoshop it to make her handson, as she describes it, look dead. And the message she was trying to communicate here is what it feels like as a mum going through the court system, the family court system, with a child when you are trying to leave a violent partner. In that she felt like she was being forced to let go of her child the whole way through. I've shown this photo as part of a wider exhibition of migrant and refugee women's photographs at conferences of magistrates of the court system and so on. And this photo, I've seen, hard-hearted judges get quite teary over this photo. And I think it speaks to the power of qualitative data and visual data to show how people feel in the domestic violence response system, which is something that can be quite hard to get from statistics. Yan, who's was one of our Chinese participants, took this photograph as an illustration of the difficulties migrant women have in seeking help and telling their story, in that they're seeking help from a system that they don't understand, where there's so many layers of bureaucracy in the health sector, in the law and justice sector, in the specialist domestic violence services, in mental health services, counselling services, drug and alcohol services, housing services. Each time they're being asked to tell their story again, and it's a difficult story, and they don't know what's going to be on the other side of the door when they reach for help. And sometimes when they get to the other side of the door, it's another door or it's a brick wall. And so she was taking that photograph to perhaps try and communicate that experience of seeking help and looking for a way out of a very difficult situation as a migrant living in a new country. And then just finally, a photograph. This is from a completely different project that was with women with disabilities in the Philippines, where we did research over a number of years with women with disabilities about sexual and reproductive health and their experiences of violence. And it was an action research project where we then took the initial data and developed pilot interventions. One of the interventions that we developed was peer support groups for women with disability, and this is a photograph of one of them there. And I include this photograph because it's a nice illustration that we did a lot of work in this project to try and improve service providers' knowledge and attitudes around women with disability and the violence that they might be experiencing, to try and increase the physical accessibility of services, making sure that there were ramps and doors that people with mobility impairments could get through, that sign language interpreters were used, and so on. But in fact, the peer support groups were really what helped women think through their own situation, recognise that they did have rights, and that they often supported each other to try and access the law and justice for their experiences of violence. So I'm going to stop sharing my screen now, and I will pass to Greg to see if there were any questions that people wanted me to respond to.
Yes, thanks very much for that important presentation there. We have had a few questions, as I'm sure you can imagine. Quite a few have come out about the pandemic, but more specifically, somebody would like to know your thoughts were on the implications of changing from face-to-face to telephone, and on the safety of taking part in research as a result of the pandemic. Yeah,
so there are pretty specific considerations in doing research over the phone and online in relation to violence against women. So some countries always have done their national prevalence studies over the telephone. Italy comes to mind. Canada is another country that does a national prevalence study via the phone. And so there are guidelines on how to do that as safely as possible. And one of the first things is making sure that you've got a system set up so that you're able to contact someone in advance and check that it's an okay time for them to speak, and contact them in a way that doesn't give away to anyone else who might be monitoring that phone what the call's about. So it is quite difficult to do that safely, but there are resources certainly available, and Greg, I'd be happy to send you afterwards some list of resources about how to do, how people have done that before to make that as safe as possible. Certainly what we're seeing in Australia is it's interesting. There's been a drop actually in requests for help over telephone lines to not all, but many of the services, but a substantial increase in requests for help over the online chat type services. So that's making us think that obviously women are able to send a text or be using their phones to be seeking help if it's not audible, but they're having difficulty safely seeking help using the telephone. The other thing that we have seen is a substantial increase in requests for help from men who are worried about their use of violence or concerned that they might be going to use violence, and we just do not have enough services working with men and who use violence. So perpetrator programs, there aren't enough of them, and that's sort of a major challenge that we're seeing at the moment.
Yeah, and so we've probably got time for another couple of questions before we move to Amit. Another question that came up was about how you change your research methodology for hard to reach populations.
I'm a big believer in using as participatory approach as possible. So working in close collaboration with hard to reach, which sometimes can be kind of easy to ignore populations. So when I work with migrant refugees in Australia, I don't have a migrant and refugee background. So I work very closely with the Migrant Women's Health Organisation, who have a team of bilingual workers, and we've trained a group of 20 women to undertake qualitative research in their own languages. And we find that giving women a choice of how they want to engage in research, whether it's in their own language or in English, increases their both willingness to participate, but also the depth of information that we're getting. It's not always that people want to do it in their mother tongue, and I think there's something about the psychological distance of being able to respond in a second language that keeps you a little bit distant from painful experiences. That means that women sometimes would prefer to do it in English, even if their English is not fantastic. But I think women should have the choice, and that should be done with community organisations who can tell you all the pitfalls and all of the kind of cultural faux pas you're about to commit before you do so that you don't lose trust of communities. Similarly, with women with disability, we always work in partnership with disabled people's organisations who often will ask quite different questions than what I would have thought of as a researcher on violence against women. You know, I've learned a lot from DPOs around things like carer violence, you know, the realities of being so dependent on a carer for day-to-day support, and what that might mean if that carer is someone who uses violence against you.
Thank you very much. And I think we'll just have one last question that's just come in on Twitter, again about COVID-19. What has been done to evaluate country responses to increases in intimate partner violence during the pandemic?
Yeah, so there isn't a lot of data yet about the effectiveness of responses, but there's a lot of data being collected. So we know from China, from the UK, from the US, Spain, Italy, Russia, increases in requests for assistance. The evaluation of interventions, I haven't seen a lot of data as yet about the effectiveness of those interventions, but I certainly know here in Australia there's sort of a lot of documentation of different approaches that are being taken. The prevalence of COVID-19 is much lower here than it is in most parts of the world, for which I'm incredibly, you know, it's partly good decisions, but partly luck, and may not stay that way. But the impact of the social isolation measures is substantial in relation to violence against women. So there's certainly data being collected about, you know, online approaches to reaching people, apps that people might have on their telephones and how people can use those safely when the phones are being monitored by people who use violence, and other strategies around in terms of neighbourhood surveillance and more kind of mutual assistance that local communities are using to support each other and keep an eye on women where they may be concerned that they are at risk of experiencing violence. So no hard answers on that one, Greg, sorry.
Yeah, but we'll find out over time, I suppose, with a lot of the things that are going on at the moment. So thanks very much for that. I'm sure we'll get some of the resources you mentioned out to people who are viewing and have registered for this. And I'm just going to stop sharing the screen, and Amit is now going to give us a presentation on measuring the Sustainable Development Goals, as he's a technical officer at the World Health Organization in Geneva. And if you're able to unmute yourself, Amit, if you can share your screen.
Hello, everyone. I'm just trying to share my screen. And oops. So can everyone see my screen, which is the first slide there?
Yeah, that's fine.
All right. So thank you very much, Greg. My name is Amit Prasad, and I work with the Division of Data Analytics and Delivery for Impact at WHO headquarters in Geneva. I'm coordinating the development and application of the WHO Results Framework, which is the way, which is a system which defines how we are going to measure WHO's and as well as countries' impacts on the health of people between 2019 and 2023. And this includes tracking progress in the health-related SDGs, which I will define further, as well as WHO's triple billion targets, which I will also define in my presentation. So we've just heard about the SDGs. We are now nearly 5 years into the SDG defined period of 2016 to 2030. There are 17 goals, and you can see that they range from poverty, hunger, health, to partnerships, peace, and life on land and life below water. So it's a wide range of issues that we cover. 17 goals with a goal on health, which is the third goal, ensuring healthy lives and well-being. 169 targets. And a target is where we have a specific, usually quantitative, but not always, but specific quantitative goal. So let's say for health, we have a target around reducing maternal mortality ratio by 30% between 2016 and 2030. So there we have a very clear target. And this is how 169 targets are defined across all of the 17 goals. In addition, there are 232 indicators that are used to measure progress towards the Sustainable Development Goals. Now, the scope of health in the SDGs is much broader than it was in the previous round of development goals, which was the MDGs, the Millennium Development Goals from 2000 to 2015. In the SDGs, health is covered through maternal and child health, infectious diseases, non-communicable diseases, injuries, risk factors, health system functions, and social determinants of health. In a Lancet paper from November 2019, many public health experts, including senior WHO officials, have identified health-related SDGs as a much larger subset than just the third goal of SDGs, which is on health. And it includes targets, 33 targets from 12 goals, which links to 59 SDG indicators. So this is our superset of SDG indicators that we specifically want to track around health, social determinants of health, health systems, etc. So WHO has a 5-year general program of work. We are in the 13th general program of work, the time period for which is 2019 to 2023. A key aspect of this particular general program of work, which is called GPW13, is that we want to have measurable impacts on the health of people. This is not something that's always done, but here we definitely want to make sure that we are able to report in 2023 what were the specific impacts that WHO and our 194 member states had on the health of people. So WHO's mission to promote health, keep the world safe, and serve the vulnerable is linked to 3 bold targets. And those are the targets that you see in the middle of the slide. 1 billion more people with universal health coverage, 1 billion more people better protected from health emergencies, and 1 billion more people enjoying better health and well-being. And together they are called the triple billion targets. They are supported by strategic shifts that you can see on the right side of the slide, which is of course stepping up leadership, driving public health impact in every country. So this is a key focus of what this particular GPW13 will be, and focusing what WHO produces in terms of norms and standards, guidelines, and other normative information on impact. So that it should be driven bottom up rather than something that's provided from the top. Now, the results framework helps us to track the progress in the impact that we want to make. So this enables us to measure the impact of GPW13 with a focus on what's happening on people's health in countries. There are 3 components of the GPW13 results framework. The first is the WHO impact framework, which is the pyramidal structure on the left. And it's based on the SDGs, measures progress via 46 outcome indicators. We'll come to this a little later. Triple billion indices, which measure progress towards the triple billion targets, and healthy life expectancy, which is a summary measure of population health. There are country case studies which paint a qualitative picture and provide a human face to the data from impact measurement and the output scorecard. The output scorecard is how we measure WHO's Secretariat's contribution to outcomes and impact. So while the impact measurement and the progress in SDGs is what the world together has achieved, especially the 194 member states and WHO and a number of non-state actors, of course, including academia and research, in the output scorecard, we want to be able to tease out as much as possible how has WHO contributed to the impact that we have achieved by 2023. So this slide is just to show that the three elements of the framework do not stand alone and are not separate from each other. They link very well with each other. They feed into each other in a virtuous circle. And success in one should be reflected in success in others. So it's a validation mechanism across three different ways of looking at it. The impact measurement is largely quantitative. The country case studies is largely qualitative, and the output scorecard is a mix of qualitative and quantitative measures. So now we'll look closely at the WHO impact measurement, which is a key aspect of the quantitative measurement that we want to take on with respect to the SDGs and the triple billion targets. So this is at the core of WHO's strategy to have a measurable impact. It will track our efforts, as in WHO's efforts, but countries, partners, regions to meet the triple billion targets by 2023, as well as the health-related SDGs by 2030. 2023 is very near the midpoint of the SDG period, or it is really the midpoint of SDG period. So it's a good time to actually take stock of what's happening, what's the progress like, and how and where we need to accelerate. So as you can see in this pyramidal structure, at the bottom we have 46 outcome indicators. These outcome indicators are largely drawn from the SDGs. So 39 of them are SDG indicators, and 7 indicators come from what are called the World Health Assembly resolutions. So this is our governing body, and through them we have identified 7 public health indicators which are related to priorities such as AMR, health emergencies, NCD risk factors, and polio. So these are the 46 indicators that together with WHO, all member states have agreed to track progress and to commit to achieve the progress. The triple billion indices are in the middle of the pyramid, and they include the three aspects that I talked about, and we'll go a little bit deeper into what these indices are, but they help us track progress to the targets. So while they are an index which measure progress, we are able to convert these index values into population measures. And that's those are the kind of methods that are needed, measurement methods that are needed, that to help us understand how well we are actually making an impact. And at the top of the pyramid is the healthy life expectancy measure, which is a summary measure of population health, which you probably know, but just to let you know that in addition to life expectancy, it tries to take into account years lived in poor health. So to dive deeper into the middle aspect of the framework, which was the triple billion indices, which help us measure progress towards the triple billion targets. You see the 3 indices side by side here. And what we want to show is how closely they are linked to the SDGs, but I will also go through what they actually contain. So the leftmost index is, of course, a very important aspect that the whole world talks about in relation to health, and that's universal health coverage. And it's the universal health coverage, not index. And that index is actually SDG indicator 3.8.1. So that entire index is already part of the SDGs. But within that, we have 14 service coverage indicators, of which 5 of them are separately SDG indicators. So whether they relate to water or they relate to an immunization or to child health, there are specific indicators there which are actually part of the SDGs. And there's the one financial protection indicator, which is related to catastrophic expenditure. Then we have the health emergencies index. Now the health emergencies index is made up of 3 sub-indices. The first is the prepare index, then we have the prevent indicators, which which are combined into an index, and then we have the respond indicator. Now the prepare index is again an SDG indicator, which is SDG3D1, which is on the International Health Regulations preparedness measure. So that's already reported by all countries. And the reason why I'm emphasizing that a lot of this is SDGs is because our 194 member states have always made it clear that one, SDGs are at the core of the development agenda going forward, and everything we do should be linked to the SDGs. And also very importantly, there should not be added reporting burden for countries so that people are not just spending time in collecting data and information. Better than that, it's better to focus on strengthening the health information systems that we have. Now, coming back to what this index is. So we have prepare. The prevent indicators are largely immunization indicators. In fact, they're all immunization indicators. They cover immunizations such as yellow fever, measles, those that are linked to emergencies. And there is the respond indicator, which tries to measure timeliness in detection and response to public health emergencies. This is a new indicator, and this is being defined and worked on with many countries. And the Healthier Populations Index draws 14 indicators straight from the outcome indicators, most of them or all of them here actually from the SDGs. So whether it's smoking, road traffic accidents, malnutrition, etc. So they are all derived from the SDGs. Now, I just want to flag that this is still a work in progress. We are at a very mature stage. We've had numerous consultations with many countries to get to this stage. All the documentation is available on our GPW13 website, which I can share with you, and you'll be able to follow the official communication that WHO has with all of the countries and the agreements that we have going forward. Now, a number of countries have helped us pilot this impact measurement system so that we know what works, what doesn't work, where are the data gaps, and whether it's actually feasible to implement this impact measurement system within countries. You can see that these 34 pilot countries are taken from across the world. We are coming to a close to the pilot in May. And after that, we'll be rolling out a scaling up to all 194 member states so that the impact measurement system can be implemented across the whole world. And we'll be able to report together next year on all of the indicators, or as many for which data is available next year in a report to provide a midterm review of progress in progress towards the health-related SDGs and the GPW13. Very importantly, we've mentioned that there are 59 health-related SDGs, which were defined in the Lancet paper. And what's very critical about them is that we need regular monitoring of these health-related SDGs to foster a shared notion of accountability of results, to help us identify important gaps, not just in data, but also in resources and rates of progress, and take into account emerging challenges that can influence the trajectory of progress. And you can possibly relate it to what's happening in the world today. Now, there are 59 health-related SDGs, as I mentioned before. The list can be found in the Lancet paper. I can share the link with Greg, so all of you can have it. 21 of them are largely collected from household surveys. 13 of them are collected from CRVS system, which is Civil Registration and Vital Statistics. 9 of them are collected from nationally representative household surveys. So that's another way of getting 9 indicators. 13 are from administrative data and 3 are from other sources. And so we actually require multiple data systems to be functioning in each country so that we can get just the 59 health-related SDGs. And how are we actually doing with relation to that? Currently, we are able to map out data for 43 health-related SDGs. This is actually using the World Health Statistics work last year. I must inform you that in 2 days from now, on 13th May, we will release the World Health Statistics for 2020. So that would have updated information. But For now, this is what we know in relation to the SDG indicators for which we are able to monitor data. And you can see that nearly 2/3 of the country have data for 75% or more of health-related SDGs. And many countries have more than 50%, but there's still 1/3 of countries which actually have less than 50% of the data. And that is definitely a big concern as we move forward. Now, we also looked at the capacity of countries to monitor health systems performance. So this is looking at some key ways of collecting data, whether it's population surveys, whether it's counting births and deaths to CRVS systems, whether it's optimizing through health service data, reviewing progress and performance. And this is actually a score package. This is a specific tool that's there for that's produced by WHO and many member states. And you can find it, I can share the link for the website. But here we see that there is better sustainable capacity to the green part for counting births and deaths. But even there, we can see that it's the number of countries for which that capacity exists is only 45. So actually some of the data collection side is not, many countries have lower capacity, and there's a lot of work to be done in terms of helping countries develop better health data and health information systems to ensure that we can actually monitor these indicators on a regular basis. I've already mentioned the issue of unavailability of data, and this is just to remind you in some key statistics what it means. It's a big challenge for many member states. It's something we discuss with countries all the time because it impacts our, of course, it impacts our ability to measure what's happening in terms of impact and what we can do further for people's health. But here you can see that 1 in 7 indicator country values had no underlying data since 2000. So we're talking about estimations here. Now, member states are not fond of estimated values. They like data coming from actual underlying primary data. But in many cases, we actually don't have that data. The 1/3 statistics I've just mentioned for approximately 1/3 of countries, over half the health-related SDG indicators have no recent underlying data. Sex disaggregated data is currently available for less than half of relevant health-related SDGs. So this is a big issue because disaggregation is at the core of what the SDG states it wants to do, looking at health inequalities. And even the most basic of disaggregations that should exist for all indicators that could possibly have it, we only have it for 11 of the 28 relevant health-related SDGs. And now, 11 health-related SDGs require cause of death data, but only half of countries are able to register more than 80% of adult deaths. And this registration of data, this counting of data is itself an SDG indicator. So just to let you know that it actually comes from official reporting as well. So now we are working with all of our member states, and we continuously work with them through official and more informal settings to ensure that we are making progress and we agree on the key strategy. So there are 4 key focus areas related to data solutions. One is around having data collection platforms, but also to have clear principles, norms, and standards, so we can have accurate, reliable, complete, and timely data. We need to understand needs, and this is where the disaggregation part is very important. We need to understand the needs of our most vulnerable communities, and therefore we need to use more innovative methods to be able to track or to be able to report on data. An international health data ecosystem needs to flourish because it will have a clear approach to privacy and interoperability. These are becoming more and more important as there are numerous data systems across the world. A lot of data is actually being collected, but we are not able to actually pull that together in an enclosed ecosystem. And working together, because there's no other way out really. It is efficient, and it is the only way we can achieve success across different programs and sectors. I just wanted to quickly go through this concept of stock takes that will help us improve results. What WHO is doing is that we are taking stock of the progress of each of the indices in our 194 countries every few months, and we are reporting it at the highest levels and coming up with not just the fact that there are problems, but what could be, what are the successes, and how can we actually work together to resolve those problems. So this is not just about monitoring, this is about finding the solutions, working together to find solutions. And these are shared at the highest level so we can keep a close eye on what's happening. And of course, our ultimate goal is to make sure that no country, no city, no community, no person is left behind. It is the people we serve and the people we look after. Thank you. I will take questions now.
Thank you very much for that, Amit. We do have a few questions here. Bear with me. They've just flashed up. So one of the questions is, do you find that some countries are quite complacent where they have actually already achieved the target in the first place?
Well, that's a very difficult question to answer. I wouldn't know, the targets are defined on a relative way, firstly. So wherever you are, you're expected to move towards something better. So if you have covered 80% of your population with respect to coverage, that's great. You're already very close to what what would be ideal, but there's always room for improvement. And I think every time we look at the world, it's not a constant. Now we have a public health crisis, which is leading into, the possibility of an economic crisis, which will impact all of our indicators. I don't think any country in the world right now can afford to be complacent. And I would say that today we are seeing all countries really trying to come together to ensure that we make a strong effort to moving forward, because the world's not going to stay static. We're going to have a changing environment. So yeah, so that's my answer.
So this kind of comes on to the next question we've had was, would there be any value in making the targets binding and giving sanctions for not meeting them?
So WHO does not have the authority to impose. There are no sanctions. We work as a technical agency, and we work together with member states to help them in the process of achieving progress that we have defined together. So it's not about punishment, but we work together with countries to make sure that we can achieve the targets. But this is something that countries have committed to, whether it's the SDGs and whether it's the GPW. This is something they track together with us. So everyone wants to achieve what they have promised. And this is what we will track together with the countries.
Oh, okay. And there was just one final question was, do you think that there's any more support that WHO can give to low and middle income countries to improve their data collection?
Yes, so in fact, a lot of focus is on low and lower middle income countries, which may have weaker data and health information systems. So whether it's in terms of funding, whether it's in terms of intellectual resources or coordination, WHO is working very closely to make sure that lower income countries have access to the best practices, and they're able to set up data and health information systems that can help them. So if you remember the map that I showed you, you'll find that, of course, in many countries in the African region, for example, are in yellow, which means they have less than 50% of the data available. So, yes, WHO does have a focus to make sure that lower and middle income countries can strengthen their data and health information systems.
That's great. Thank you very much, Amit. If you're able to unshare your screen.
Yes, thank you.
I'll pass it over to Julian and Jennifer, who are both directors of social responsibility at the University of Manchester, and they're going to talk about how you can contribute to the Sustainable Development Goals across research, teaching, engagement and operations activities.
Yes, hello. I hope people can hear me first of all. Just check with you, Greg, that you can.
Yep, I can.
Yeah, and can you see me at the moment? I'll share my screen in a moment.
Yeah, we can see you at the moment.
Brilliant. Always worth checking that. Hello, everyone. I'm really pleased that you're able to join us today. We're here from Manchester. The background in my slide is of the university campus, which I'm really missing. I'm not allowed to be there. It's a false background, and the weather's not as nice in Manchester today as what it is in my photograph. So today, as Greg has been saying, Jen O'Brien and myself, we both work at the University of Manchester. We're going to tell you a bit about what we've been doing in relation to the Sustainable Development Goals more broadly. And obviously the audience here is a public health audience. We will touch on that, but what we're going to do, you're talking a lot today about SDG3 in particular. We're going to talk more broadly about the Sustainable Development Goals, and not just what our university does, but what the role of universities more broadly are in contributing to the Sustainable Development Goals, because universities themselves as institutions throughout the world have a very important role in addressing the SDGs. So we'll take you through that. I'm going to talk for about 10 minutes, and then Jen is going to come in and then talk for another 10 or so. And then it probably makes sense, Greg, if we take questions together, Jen and I, after that. Yeah. So I'll take it away then, and I'll share my screen. Just a moment. Share screen. PowerPoint share. So can Greg, is that, you've got the University of Manchester screen there, is that okay?
Yeah, that's it.
Yeah, fantastic, thank you. So the first thing to say then is who I am. So I'm Julian Skryme, and I'm the Director of Social Responsibility at the university. So I have a role that spans right across the institution, and I oversee the university's strategy for how we address social responsibility. And I'll say a bit more about that in a moment. This is our campus, which you can see in my background. I wanted to sort of start with that to say that for many of the people around the world tuning in today, just to note a little bit of information about the university where I work and where Greg, who's hosting this, works as well. So we are the biggest campus in the UK. So in terms of number of hectares, if you like, a number of buildings, we're the largest. Ourselves and UCL are the two largest institutions in the UK. So we're very large. We have around 40,000 students, about 12,000 staff, and we're in contact with around half a million alumni, around 500,000 alumni. So we're a really big community. In terms of some other key facts about the university, we've been around a long time, nearly 200 years now, and we've got some really interesting heritage. I think we've got 25 Nobel Prize winners among current and former staff and students. So one famous one, perhaps the second person to get a Nobel Prize at Manchester, was Rutherford for the work he did on splitting the atom, for example, right through to today, our physicists that isolated graphene in Manchester in 2010. Other things which Manchester's quite famous for, I guess, is inventing the computer that could store memory. That's a really important development that happened. So some of the other things I thought it'd be worth you knowing as well is about our goals within the university today. So we have 3 core goals. One is to do world-class research. So discovering knowledge and sharing that knowledge. The second goal is around providing outstanding learning and student experience. So those are the 2 traditional core functions of the university: discovering new knowledge and passing that on. So discovering the new knowledge is the research, and passing that knowledge on, whether that's to our students or more broadly to the public, is around our learning. Unique in British higher education is we have this 3rd goal of social responsibility, which Jen and I work towards, although Jen, as she'll explain to you as well, works on goal 2 as well. And what she's going to talk about is the intersection of all 3 of these things, actually. But Jen is very much involved in taking forward innovative forms of learning within the university as well. So there are 3 core goals. In terms of where we stand, in terms of the quality of what we do, if you like, at Manchester, so we've been a sort of a top 50 university for some time now. In there's various rankings of universities. There's a couple there, one where we feature 27th, another we feature 33rd. In terms of our impact on social and environmental factors, though, we have featured first in the UK for the past 2 years, running in a new ranking which has been produced by the Times Higher Education, which is based exactly on the UN Sustainable Development Goals. In terms of our heritage as well, we were the first of what people call the civic universities, institutions that developed royal charters outside of London, mostly in Victorian times. And that's really important, that civic history of Manchester in terms of the type of institution we are today. So onto the Sustainable Development Goals. I won't say what they are. You've heard a lot about this, and I'm sure everybody listening today knows quite a bit about the fact that there's these 17 goals and there's various indicators and targets, as you've heard in the last presentation. What I do want to say, though, from the perspective of a university, these are enormously important, and they're important for many reasons. This slide, I'm not an astronomer, but I think you can see when you look at this slide, there's something she's doing wrong, and she's looking exactly through the wrong end of that telescope. And I think this is a good metaphor for sometimes the way universities have thought about their relationship to society. Those of us, I know there's many people in this webinar today who work in universities, we're not always the best at aligning what we do, whether it's the language, the concepts, the way we think, the drivers, the funding, the reward system, aligning those things to what the needs of society are. And there's been something, perhaps particularly with the rise of populism around the world, there's been something of a disconnect between experts, of which universities are a part, and their wider populations. And part of that is, I believe, that people don't perhaps understand as well as they should do what the purpose of a university is and what its benefits are to society. And some of that is our own fault, perhaps. I think some of this is the style of particular forms of politics, but also we can't just say there's no responsibility upon ourselves as universities. So universities have a very important responsibility, in our view, in Manchester, to connect what they do to real world challenges and issues and problems that exist. And what better framework to align ourselves to than the Sustainable Development Goals, of course, because these are goals that are universal. So they don't apply just to the UK in my context, they apply to the whole world. They don't just apply to developing countries, they apply to the global north as well as the global south. They don't just apply to universities, they apply to the private sector, they apply to the public sector, and they apply to the third sector, of which in the UK at least the universities are a part. So they apply to all different sectors. They also apply to citizens as well. What can we do as individuals as well as to governments and to corporations? So they're an amazing framework within which you can think about the purpose and the impact of a university. So we've been doing a lot of thinking about how can we align ourselves to these goals and also use these goals as an opportunity to really tell a story and also to reorientate some of the activities within the university. So I was just going to say something very brief about that. So before I do this, I'm going to attempt to share a video with you now. I hope I'm not going beyond my technical competencies. So I'm going to press stop share. Nothing is going wrong. Get my YouTube video on and click to share again. So just a moment, I'm going to try to do this. Very ambitious, I know. Right. Share screen. Google Chrome share. Here we go. So you should now, and I'll just ask Greg, you should have a blank screen ready for me to press play. Is that what you've got, Greg?
Yeah, that's correct.
Fantastic. So I'm going to play you, this is interesting, isn't it? I'm going to play you a YouTube video within YouTube that you're watching. So let's see if this works.
In 2015, the world's nations developed 17 new priorities to end poverty, protect the planet, and ensure prosperity for all. These are the United Nations Sustainable Development Goals. At the University of Manchester, we believe universities exist for public benefit, and our commitment to social responsibility means that we're addressing these global goals through our research, learning, public engagement, and operations. We are responsible for producing 4% of the UK's research on the Sustainable Development Goals, and we provide an accessible learning environment for students to address these goals. We engage with the public and maximise social and environmental benefits through our operations. We're addressing inequalities in labour through our pioneering partnership, The Works.
I just thought it would be one of those typical kind of employment places. You go there, you have to tick all the right boxes, and then you leave again. If you get the job, you get the job. But it was nothing like that.
The Works offers a one-stop employment service in our local community. And through it, we've supported over 4,000 people from our local communities into work at the university, and with local partners, generated over £60 million of value each year. Tackling the world's biggest challenges requires global thinking. We're supporting gifted professionals from Uganda, Rwanda, Tanzania, and Ethiopia to address the Sustainable Development Goals through our master's programs.
I was the recipient of the Alan Gilbert Scholarship, and through their generous support, I was able to do my one-year master's urban planning program. The experience I got from Manchester was the diversity. That interaction with different students from different areas was enriching for me. 5 years down the road, I'll be sharing my knowledge across the region and helping to build much more sustainable cities.
Over the past decade, 287 full scholarships have been awarded. These scholarships are fully funded by the university and the generosity of our donors. Demand for energy and irrigation services is growing and being met through 3,700 new dams around the world. Future Dams is an £8 million global research collaboration led by the university to improve the sustainable design, selection and operations of dams. At the University of Manchester, we've assessed our contribution to all 17 Sustainable Development Goals in a pioneering new report. Our impact against these goals was ranked the best in Europe and third in the world by the Times Higher Education University Impact Rankings. Whether you're in the UK or overseas, the public or private sector, policy or education, a funder or an NGO, let's work together to tackle the world's Sustainable Development Goals by 2030.
Okay. Greg, am I back on screen now? I should be.
Yeah, you are.
Thank you. Okay, so what I'm going to do now is pass over to Jen, just to say, by way of conclusion, what we've been doing at Manchester is we produced a report, and Greg can share a link to this as part of the proceedings. We produced a very comprehensive report into our impacts against the Sustainable Development Goals. And as the video indicated, we were thinking about our impacts in 4 main ways for a university. So yes, we do research. So take all of the research, and let's take the example of COVID-19. Why not? You know, a topical example. You could look at what our impacts were on COVID-19, as you can, which is obviously a communicable disease, which the SDGs, SDG13 looks at reducing communicable diseases. You can think about that issue in 4 different ways if you're a university. You can think about the research you do. So yes, we have virologists and immunologists who are doing research right now on COVID-19. So yes, we can produce new knowledge. Secondly, we can pass that knowledge on, and Jen's going to talk about that in a moment. We teach, so we are teaching people immunology, virology. We're teaching people about the relationship of air quality and how that changes during the current pandemic, for example. So we're teaching all these things in the university. The third thing is we're doing public engagement. We're reaching out to the public. So lots of our academics are doing things like we're doing today. They're speaking to the media, for example, and have a very important role as public intellectuals. We have opened up our university museum online, and that's a way which we can reach out to the public with particular issues. So there's a public engagement function, thirdly, and then fourthly, we have operations. Universities, in many cases around the world, are often the biggest spenders, the biggest employers, the biggest economic actors in their areas. and they have many privileges really as anchor institutions in their areas, as big employers and big spenders. So take the University of Manchester. It's the second biggest employer in the city of Manchester after the National Health Service. We're based right next to the hospital. So we have a car park in the university, for example, at the moment, which is totally empty. And we've given over access to that car park to visitors and NHS staff during the current pandemic, because more and more people have been working in the hospital at any given time and they didn't have enough car parking space. I say that as an example of something a university can do through its operations. We exist as a big economic actor. What can universities do to take to make more use of the fact that they're such big employers? So you can look at different aspects of the Sustainable Development Goals in those 4 different ways: our research, our teaching, our public engagement, and our very operations, how we exist and what we do to exist. So we did this report looking at all 17 SDGs using those 4 factors, and we'll send a link around to people to look at that. And we thought it was a really good way to think about our impacts and also then start to set ourselves some goals and targets ourselves within the university. And one of our goals very much was around how we orientate our learning experience more to students to prepare them for the type of world they will enter in, where these are the main goals in the world. And that's a really good point now to hand over to my colleague Jen, who's going to talk precisely about this. So I'll pause there. We'll take questions once Jen has finished, if that's okay, Greg, and we'll try and bring Jen in now, and I'll mute myself and Jen will unmute herself, and magically we will transition from one part of Manchester, where I am, Whalley Range, over to another, which is called Levenshulme in Manchester. So seamlessly we will move across.
Hello, can you see me?
We can, Jen, yeah. You
can, thank you. Thank you so much for welcoming me today. This is so exciting. I wish I knew how many corners of the world I have the honour of talking to at the moment. Forgive me, I wanted to say hello if you'd have to see a face, but I'm going to switch the video off because my internet is having its own lunch break at the moment and is struggling ever so slightly. So forgive me for being a haunting voice that is talking at you for the next few moments or so. I work in an incredibly collaborative way, so please do feel free with any questions or thoughts you might have, either through the Twitter or directly to me after the presentation. So my name is Jen O'Brien. I am a senior lecturer in geography. I specialise in sustainable development, and I'm the Director of Social Responsibility for the School of Environment, Education and Development. So I technically work under Julian's leadership for the University of Manchester. And as Julian kindly outlined, there's a big picture of the role of the Sustainable Development Goals within the University of Manchester, which speaks very closely to our 3rd goal of social responsibility. And what I'm going to do for the next couple of minutes is to try and narrow that down, narrow the focus in, and to explain a little bit about how I believe the Sustainable Development Goals can be used within teaching and learning to affect change. And this is where, as Julian outlined, the University of Manchester has done spectacularly well in the Times Higher Education rankings of SDGs, but I'm sure any educator or professional worth their weight in chalk dust and promotion applications would critique the role of metrics. But what I really like about these rankings, as Julian mentioned, is that they open up space for new partnerships, new opportunities to affect change. And I believe in the SDGs as a major lever for change. But actually, as Cathy alluded to in her earlier presentation, that's a huge challenge. It's often much easier said than done, particularly in such a rapidly changing world that we live in at the moment. Some of these slides you've seen before, I quite like that we've all used the same image of the Sustainable Development Goals. And I'm sure many of the listeners are aware of the fact that the SDGs transitioned for the Millennium Development Goals. And there was this notable shift from a focus on poverty towards a focus on inequality. And that was quite a political move. It required immense commitment from all nations involved at different scales, commitments around finance, around actually impacting change through the SDGs, and drew very, very importantly on partnership. Now, I'm sure many people know about the triple bottom line of sustainability as outlined in the Brundtland Report of 1987. We're used to seeing this idea of people, planet and profit coming together for sustainable development. But under the SDGs were added these 2 additional elements, peace and particularly partnership. And I find this truly fascinating. Partnership is a really interesting notion, concept, ideal, particularly in sustainable development. It's so easy to say, and yet decades of development thinking have critiqued the romanticism of notions of partnership, of even participation, working with people on the ground, ensuring that no voice is left behind, that the needs of the most marginalised are heard, and preferably are leading the agenda in a most participatory and fair way. Really challenging to work across multiple scales, incorporating all of those voices. And above all else, partnership requires really good governance at every stage. And this is where, to me, this idea of partnership, which is seen as one of the quite discrete goals, is actually really essential and becomes almost like the bedrock, the foundation of achieving the Sustainable Development Goals. This becomes even more challenging if you think about the crazy different interlinkages across the Sustainable Development Goals. And Amit referenced some of these, albeit tangentially earlier when we're talking about the breadth of SDG 3. You can look at SDGs in all sorts of different perspectives. These are just 3 that I picked up on that show different ways of viewing them. The one at the bottom from the Stockholm Resilience Centre uses food to frame the SDGs around the triple bottom line of sustainability. The goals are huge. The different measures, there's 169 targets within them. Again, as Amit said earlier, we still don't have a complete methodology to measure impact or kind of real achieving these targets. Perhaps that's where the role of data comes in and big data. But it's really hard. And as Julian introduced earlier, the SDGs are supposed to be as applicable to Manchester as they are to Malawi. And this is where, to my mind, the notion of partnership is so, so very important. And particularly, that partnership becomes more acute under COVID, which I guess is a natural discussion, a natural framework for our discussion today. And please forgive me, I don't for a second mean to sound heartless about a pandemic that has led to hundreds of thousands of deaths globally and is immensely entrenched inequalities at every scale and will have lasting impacts for decades to come. But I am a great believer in learning from experiences and seizing every possible opportunity. And that can also go some way to reduce the sadness. I heard a wonderful quote recently, which is attributed to Damien Barr, which does that when it comes to COVID, we're not all in the same boat, but we are in the same storm. And to weather that storm more than ever, we need to work together. So some of our colleagues at the University of Manchester, Dr. Rory Horn and Professor Hume, just published a recent paper that talks about the needs for institutions and norms to recognise that we all live in one world. And arguably, this is where COVID presents us with an opportunity to press the reset button on quite a few structural and institutional challenges, some of which we're already seen about expectations introduced around airline funding, for example, and the expectations. The French government have just asked Air France to consider its carbon emissions, for example. The UK government has invested a lot of money into walking and cycling. We're seeing great things. Now, as Julian outlined, universities more than ever are being challenged to demonstrate their purpose and public benefit. So whether it's through climate crisis or the public health crisis of COVID, suddenly more than ever, we're thinking about the role of scientists, the role of policymakers. And I would argue that we are educating the professionals of the future. So the way that I see it, my students are a 40,000 strong force for change. And our students want to make change. So here for me is a new partnership, a partnership that I would like to develop. And let me explain to you a little bit why. So I see the SDGs as a framework for effective pedagogy. So moving beyond metrics and measurement, actually utilising the ethos, the spirit of SDGs in our teaching and learning. So the wheel up here speaks to the different ways in which our courses, our learnings links up to the SDGs. I promise to shamelessly promote the fantastic work of a colleague of mine, Dr. Roger Harrison, who's just launched a superb free course on antibiotics. That Unroll Here link is a live link if anyone can access it. It's a free open course, and I don't need to tell most of the audience, I'm sure, that antibiotic resistance is now on the WHO's top 10 list of major threats to human survival. Julian identified a number of ways in which our teaching already speaks to the SDGs. But as a framework for pedagogy, the SDGs opens up opportunities. So I'm trying to really embed those principles and those practices. So I use Education for Sustainable Development, or ASD, which is a framework for learning and operating. ESD is rapidly being recognised internationally as an integral element of quality education, and it's a key enabler for sustainable development. So taking an ESD approach, you can deliver, I would argue, quite a transformative education by reorientating learning in its broader sense to develop knowledge, skills, values and behaviours that are needed for sustainable development. And this is where we're encouraging individuals to become responsible actors who resolve challenge, respect cultural diversity, and continue to contribute towards making a more sustainable world. So this is where I think some of the core premises, some of which have been outlined today across the different presentations of the Sustainable Development Goals, and particularly partnership, but also data, the premise of leaving nobody behind, these all become an incredibly valuable learning opportunity, but also one that I would argue could propel sustainable development and that you can apply to any learning space. Now, forgive me, I'm quite enthusiastic about this. I could talk to you for hours, but let me give you just one example that we've been working on this last year. So we've delivered a new course through our University College of Interdisciplinary Learning, which runs through the University of Manchester. It's a unique centre that offers courses to any students who have free choice credits. I really like that it's online, and again, embodying the principles of the SDG. That means that it brings flexible learning to perhaps learners who are part-time, they have caring commitments, they need to work, or just want to change in their way of learning. It also means that our learning spaces are constructed by medics, by social anthropologists, by mathematicians, by engineers. And together, we can then construct new spaces of learning that cast a different lens, a different collaborative light on old problems. Now, for any of you who work in British higher education, I'm sure you've heard of the classic 1990s adage, as students as partners. But this is where genuinely working with students in a mutually respectful manner, I didn't half learn. I learned so much from my students. We invited students to feed back at the end of each module, to apply their knowledge, recognising the diversity of their backgrounds and their interests. Students challenged me, and there were times at which I had to change the course overnight. Bringing these voices together, over 80 voices from policy, practice and the academy, drawing across those multifaceted interlinkages of the SDGs that I referenced earlier, enabled these different viewpoints, these different insights. And of course, we drew upon the big hitters of the university, Professor David Hume that I referenced earlier, and Professor Kevin Anderson, but in endeavouring to capture the insight of more than just the white male professionals, no offence if you happen to be listening, Professor David Hume, but we engaged voices from the field, from across the Global South, through NGOs, through CBOs. Rosemary Nakwame, if you're listening, Rose runs REMI East Africa. She's one of our Equity Merit Scholars. She contributed to our SDG3. Sarah Lager, who's also one of our Equity Merit colleagues, led the Gender Equality SDG5 module, and she's currently looking at PhD opportunities. Again, working together, different insights, different viewpoints, enabled a different way of learning around the SDGs. And another element to that was utilising applied real-world research, which I'm just going to talk through to you very quickly for the next minute or two. So given the nature of the audience, it's natural here for me to draw on SDG3. Good health is often abbreviated too, but as we know, good health also encompasses well-being, which makes SDG3 a truly massive goal. Amit talked earlier about how it covers everything from health systems through to MMR, IMR. It talks about Ebola and malaria through to non-communicable, more social science health issues such as smoking and traffic accidents. And I should absolutely acknowledge my appreciation of Dr. N.M. Hack from UM's Medical School, who gallantly led our SDG3 module for the USIL course, trying to navigate a way to bring together some coherent learning experience for the students in such a huge goal. Lost amongst SDG3 is air quality, which I would argue before COVID-19 was set to be our next health epidemic. Now, an immediate partnership is illustrated here because this is how I first met Greg. Right now, by rights, Greg and I should be equipping 100 students with air quality monitors through Plume Labs. And Greg, I promise that we will eventually, we will do that at some point. But air quality is complex. Clean air is essential at multiple scales across the world, and particularly now that there are proven links between air pollution and vulnerability to coronavirus. So a 2018 report by King's University identified that reducing PM 2.5, so particulate matter 2.5, and nitrogen dioxides by 1/3 in Greater Manchester would add 3.5 months onto every single person's life expectancy and save somewhere around £500 million per year. Now, the lockdown due to COVID has already reduced our nitrogen dioxide levels by more than half. So the images on the right-hand side here, UK-based, looking across London from slightly different aspects before and after COVID. I'm drawing upon some local examples here, but equally you could talk about the fact that suddenly the Himalayas are visible again from Delhi. We've seen massive air pollution reduction in China, which is actually beginning to pick up again now lockdown has lifted. So the coronavirus lockdown has transformed human activities in urban data, and our urban data can show how that has happened. And this is where, drawing upon these new partnerships, linking together our research and our teaching, we've been able to identify this. So the University of Manchester's Urban Observatory worked in partnership with Transport for Greater Manchester and Manchester City Council, who shared with us some of their data. This is traffic movements before and during lockdown. And we've been able to better understand the impacts that data can have to make us think differently about using space and think about impacts that can be put into place. What I thought was really quite interesting is, despite all these massive levels of big data, often, and again, as Cathy referenced before, some of the qualitative, more human, on-the-ground community insights are also really important. So the image here is of a few bollards that have been put up towards as you approach a local school. This was fed into this big consultation, lots of high-end traffic planners, and these were mums saying actually a really simple way to improve air quality around schools is just to stop cars idling outside. So what we begin to see is an illustration of how this very seemingly simple goal, SDG 3, good health, actually speaks across a whole different host of the Sustainable Development Goals, with very much SDG 17, partnership for the goals, in the middle. And these are some of the tensions that I'm trying to tease out into our pedagogy, getting our students to think about the linkages across the goals and their insights or capabilities to enhance change by thinking across those linkages, working together in interdisciplinary partnerships, applying their different lenses and understandings. So we're bringing this together through this concept of University Living Lab for pedagogy. The concept of Living Lab is now a little bit older. It very much draws upon this premise that universities can be seen as sites of experiments. We can do more than just reduce our impact on the world, but we can actively contribute to it. It's now really quite critiqued, and one of my critiques is that pedagogy is missing from that. So what we're doing is engaging, deploying, if you like, our 40,000 strong for potential change in real world research to affect change. So we're equipping our geographers, for example, with our plume air monitors. We'll do the same with Greg's students as soon as we can after lockdown, because I do promise I owe you that one, Greg. And we're utilising these partnerships for data collection, for the analysis and the interpretation. And what I'm trying to do is to bring together this open resource platform, that can share needed research, interesting projects that will engage our students from an interdisciplinary viewpoint and in turn can affect change. And in my second kind of shameless plug of this short presentation, any projects that people might have that you'd like to deploy our students, would like to work with me in partnership on this great expedition, please do feel free to get in touch. So this is where I would argue, to bring it to a close, that education for sustainable development empowers and equips our learners to affect change at all scales and in all learning spaces. So I've given you a whistle-stop tour of just a couple of examples today. And this is really drawing on the premise, the core, the ethos of the SDGs, leaving nobody behind, working together in partnership, drawing on data, and really affecting change. And as I say, any thoughts or contributions would be really very welcome. Thank you.
Thank you very much, both of you there. If you're okay to just unshare your screen, I'll go through a couple of questions that have come in. So on the teaching, how engaged do you actually find the students in regard to the SDGs?
Jen, did you want to answer that?
So I'll be honest, mixed. What I found in my experience is the students that are aware of the Sustainable Development Goals are very engaged, they are very aware, they're very active. There was some research done by the National Union of Students, I'm going back 3, maybe 4 years ago now, time flies, that identified that students who didn't know about the SDGs wanted to know, but fewer students knew about the SDGs than the research was expecting. What I have found is that students are incredibly, forgive me, woke. They want to know about real world issues. They're very aware. We've seen the huge movements under Greta Thunberg, for example. I think students are much more aware, certainly than I was at that stage, around kind of real world issues that speak to sustainable development, especially framed through climate crisis. I think there is a growing awareness of the SDGs. One of the challenges for me is identifying areas that don't naturally speak to the SDGs, at least on the outside. So geographers, all my geographers are aware of their impact on the environment. Harder to make that language accessible perhaps to dentists or engineers, again, opening up new partnership potentials.
Okay. I'll just come in there as well. I think there's another interesting aspect to young people and how they think about university and their choices. So traditionally, students, of course, would look at things like which city was that university in and what they wanted to study and what's the nightlife like, etc. But what's really interesting, picking up on Jen's point about students being more woke now, you can see it in the data as well, that choosing a university, students are more likely to take into account that university's commitment to sustainability in its broadest sense when making choices about university. And I think that's a really interesting factor. So actually universities performing well and taking these issues seriously through their teaching and through their research, but also how they operate. Are those sorts of campuses sustainable campuses? That's going to have an increasing level of importance on students' choice of universities, we think.
Okay. And I've just, we're running a little bit over, but I'll just do another couple of questions that have come through. Somebody said they would be very grateful to learn about how blind, deafblind, partially sighted and disabled people have been incorporated into the SDGs at the university report. Please, in respect for the need for safe and accessible urban environments, in particular around active transport solutions for walking and cycling.
Yep. So just to say that obviously there's an SDG on inequalities, obviously reducing inequalities, and that's where most of the question, which we just had, some of the indicators there, certainly within our university, we would frame them within that aspect. So yes, universities, as I said in my presentation, when you think about what our impacts are on something like this, like a physical disability in this instance, we do research on these areas, we teach about these areas. We reach out to the public, but of course we have our own operations as well, the way our own campus operates. So thinking about the accessibility of our buildings, thinking about online access now, which is really important for our students because we're teaching wholly online. So how does that impact on different groups of students? And we're seeing big impacts actually, as well as disability issues like social class as well. Some students having better access to good quality internet connections, for example. So that's a really good example of an issue which you can think about from a university in those 4 ways I outlined earlier.
Yeah. Okay, and one final question before we go to Jo for her presentation. So when discussing partnerships as an anchor institution, does the university link with other anchor institutions around Manchester to contribute to the SDGs?
Jen might have some views on this. I certainly do. Yes, you know, we really pride ourselves on those partnerships. We can't exist without them. So you think about that core business I talked about earlier of a university, researching and teaching. Where do we get the research questions from? The best research questions. In many instances, particularly in the sorts of disciplines in the humanities, which Jennifer and I would align ourselves to, they often come from those partnerships. In the first place, I think in terms of our teaching as well, we're increasingly seeing people who want to orientate, like Jen's doing, their teaching to real world issues, connecting them to community groups. So for example, even a subject like history, you might think, well, how can you connect history to real world issues? Surely it's an abstract academic subject. Well, actually, there's lots of really interesting public history. So we've linked our history students to the development of a local park near where I live, which is trying to engage people by using its heritage, its amazing heritage, to make it more accessible to people and get more people to use it, because it was a park that used to suffer from a lot of crime because not enough people used it. So using history in a really positive way to address a real world issue, that park is somewhere now that people go to enjoy nature for their well-being. It has really important environmental benefits, and I think it's really thinking through then how you can use the SDGs and use those partnerships. And as Jen mentioned in her presentation, that's an explicit part of the SDGs, SDG 17. Jen, it'd be really good if you give your perspective, because your program, I think, was a brilliant example of linking students' learning to partnerships outside the university.
Yeah, absolutely. I mean, certainly as I outlined, the University Living Lab for Pedagogy is entirely about working with organisations externally from the university as well as internally in partnership. So our external organisations giving us research they want our students to undertake. Oh, I hope that's not me. And literally linking up those skill sets within different partnerships. We've piloted this for a couple of years now. It's a great opportunity for our students to work with organisations at different scales. Some of them are quite small, emerging organisations through to kind of more recognised, established ones. And it also means that the organisations get, if you like, some input from very of the moment students who can find out new things for them. It's an exciting new world.
Brings us a good time to move over there with the exciting new world. Thanks very much for your presentation. It's good to see some of the stuff that's going on in the university. And now if Jo can unmute herself and share her screen. Professor Jo Boufford, she's the clinical professor of global health at New York University. And she was also the immediate past president of the International Society of Urban Health. And she's going to give us a talk on healthy cities. I think you might just need to unmute, Jo. Oh.
Hi, good morning, afternoon, and evening to everyone. Let me first thank Greg and the University of Manchester and the European Public Health Association for this invitation. I'm delighted to be talking to you today on the topic of cities as drivers of global health. And I am presenting from the New York City, the epicenter of the US coronavirus pandemic, but I do also, I'm really going to, I'm happy to take more questions about COVID-19, but I'm going to kind of allude to it in my presentation, because I think one of the things that we see happening very much in New York is this sort of the very strong attention to the pandemic and to planning for not being flat-footed the next time it comes around is often obscuring many of the ongoing emergency situations and also shining a light on existing disparities and problems that we've known about for some time. So I'm going to try to weave that through my discussion. First of all, let me put urbanization in the, hold on, I'm having trouble moving this, just one second. Greg, I'm having trouble moving. There it goes. Okay, let me put urban health discussion in context. I sort of think of it as one of sort of four major public health challenges for the 21st century, along with these other items on the list. And let me just touch on each of these briefly before coming back to urbanization. First of all, the issue of non-communicable diseases and injuries. You can see from this slide that up at the top, the highest death rate is still caused globally caused by cancer, cardiovascular disease, and the public health victories actually of the declining mortality from acute infectious diseases like HIV, TB, and malaria, although much of that may be challenged now with the COVID challenges. But buried in that bottom group is the road traffic accidents, which are increasingly of importance and connected to the broader determinants of health. Aging, demographic shift is another of the major challenges of 21st century public health. This shows the trend data on percentages of the population over 60. And you can see while the world is sort of in the middle with the red line, and the more developed regions obviously have a much higher number of individuals over 60, the slope of low and middle income regions and countries is increasing slowly. So aging has become a global issue, not only an issue of the North. And then finally, climate change. This is a whole full conversation, but one of the characteristics of cities has been the heat island effect and sort of the notion of concentration of heat. But also on the climate change issues are the heat factor we know has been particularly troubling for vulnerable populations, older persons, younger persons, individuals who are not able to air condition or condition their internal environments in their residences. And also another area that's increasingly being looked at is the productivity of the workforce in very high temperature situations. So this is a real concern. And similarly, the fact that most cities are on bodies of water. So the issue of sea level rise is a huge issue for certainly for cities like mine, New York and others. So going back then to the issue of urbanization, the question is sort of, why have we started paying more attention to cities? The easy answer is that a few years ago, the exact year is still a little bit debated, but more than half the world's population began to live in cities, and this number is projected to increase dramatically over the next couple of decades. And I think the other factor here is that while historically urbanization had been seen as a high-income country issue or an issue of the North, it's now a global phenomenon, and you can see the slope and growth of urbanization in low and middle income countries. Now, another reason to look at cities, and the reason why I flag them as critical factors in achieving the Sustainable Development Goals and global health, is that while cities are extremely attractive, they are really the engines of the economy in most countries, responsible often for up to 70% of the GDP in a particular country. They're also centers of communication and culture and innovation. They also are responsible for over the majority of global energy consumption, greenhouse gas emissions, and global waste production. So the message here that is, without addressing these conditions in cities and leveraging the economic driver value that cities have, we really can't achieve global health goals. Now, cities have emerged, and there are networks of cities globally. These are examples of 3 of them. And many are finding it attractive to work with cities. Obviously, it was a big leap to go below the national level of government to deal with cities in the SDGs. But we have networks like the UN Compact of Mayors, C40, very well known for climate change leadership, and most recently air pollution, especially, and age-friendly cities, among others. So there are a number of networks, and mayors are increasingly responsive and visibly responsive to issues in which national leadership are really not able, for political reasons, or not willing for political reasons, to step forward. And people are focusing also for that reason as cities as change agents. Now, there are sort of 4 characteristics of cities that are used by many who do research on urban health: density, diversity, complexity, and inequities. And I'm going to touch on each of these. I think the message I want to leave you with is that urban environments and cities are neither bad or good. It all depends on the quality of management and the quality of governance to try to maximize the positive effects of these factors and minimize the negative ones. This is a chart of the sort of greater metropolitan areas to address the issue of density. This is an issue that's gotten huge attention, appropriately so, in the current COVID-19 epidemic, but you can see just the massive growth in greater metropolitan areas over the last 15 years or so. Diversity is another characteristic of cities. This is a borough in New York City, which was very much in the press recently, Elmhurst Hospital being the hospital that serves Queens along with another public hospital. But you see here the challenge for public services with the very large number of languages spoken, subgroups, and others, meaning that one really has to tailor and localize messaging for public health and engage with communities to engage them in working with you. And on the other hand, this is exactly the kind of characteristic of cities that makes them attractive to people who choose to live there. Complexity is another feature of cities. This is the organizational chart of the city of New York. I'm not going to go through it, nor will there be a test after, but the big message here, and I think this is true for most large cities, is the organizational structures tend to be quite vertical. This means that agencies of government have mandates, they have multiple programs and responsibilities, and we really need political leadership to bring these multiple actors within government together to tackle and develop shared goals, and similarly to engage with the private sector and with civil society organizations, as was discussed a moment ago. And then the final characteristic, which is really baked into urban health considerations, we don't have to remind ourselves, we live with this all the time. And I think this is an image from New York. If you look at the two age clusters in the middle from 76 years to 85 years, that's 3 subway stops on the city of New York between East Harlem and the Upper East Side of Manhattan. And it really does underline the reality that very often your zip code may have more influence on your life expectancy than your DNA. So one of the challenges in talking about urban health is really introducing the concept of how health improvement is produced. In my experience talking about urban health, especially to global audiences, is very often when people hear the word health, they think about healthcare, personal health care, and they either stop listening or they expect you to start talking about hospital capacity or primary care, all of which are important topics, but aren't necessarily the only, and certainly in many countries, the only factor in achieving health. This is a pretty iconic diagram. It shows you how long we've had the sense of how health improvement is produced. But recently, we've begun to develop an evidence base to verify the fact that while individuals are born with certain characteristics, their family environment, the conditions in their community, and then in the city or nationally, the health policies that shape communities are all important and need to be addressed to make change. And so this is a diagram that we've been using in the International Society for Urban Health to point to the fact that there are multiple sectors that help make cities healthier, and that decisions are made every day in each of these sectors that can either be health promoting decisions or decisions that undermine health. Transportation is one of the most visible in the sense that decisions to invest transportation dollars in mass transit and active transport, such as bike lanes and walking or sidewalks, even in some cities, is quite different on the health impact on issues like obesity and mental health, really, in terms of being outdoors, walking, and taking advantage of environments, and the issue of cars, more cars, air pollution, road traffic accidents, etc. So these decisions are important, and similar ones are made all the time in design of built environment and urban planning, housing design, education, etc. And then just to focus on the governance bubble at the bottom, which is to reiterate the importance of political leadership and good governance, meaning government with other partners to make the positive choices, the choices that are most often taken. The health in all policies approach has been around for a long time in global health, thanks to our colleagues in Finland who wrote, I think, the first book in the 30s. And I think we're beginning to understand how important this is. as a conceptual framework for achieving urban health in those multiple sectors. The idea of the health and well-being of citizens is critical to any country's social and economic development. If one only thinks of health as healthcare, it becomes only, in a sense, a cost center for a country. And increasingly, this has been recognized. Again, all policies that are can have an impact on determinants of health. And very importantly, the next bullet, the impacts of determinants are not equally distributed. So the issue of equity and health disparities really has to be addressed, along with the questions of partnership. SDGs, we've seen this picture a lot recently. The ones that relate to urban health are SDG 3 and 11. Using the framework of multiple determinants of health and using the notion of health in all policies, this is goal 11 for cities. And this is a goal that is being largely taken up by UN Habitat in partnership with WHO. But if we think about the multiple determinants, you can see on this list of variables in inclusive, safe, resilient, and sustainable cities, we see housing, transportation, air quality, green space, etc. And yet in this goal, it's very hard to find the word health. And happily, the UN Habitat has been developing the new urban agenda, and the UN Secretary General has taken forward a single UN to develop thinking about urbanization, the process of urbanization. And over the last several years, WHO and UN Habitat have been collaborating in very important ways to look at issues of housing and air quality, and are planning to put a casebook out shortly, which may be impeded a bit by our coronavirus shutdown, but I think it's really trying to help us think about how goal 3 and 11 can come together. This is a big shift, looking at broader determinants of health from the traditional, I would say, medical model for disease prevention. My career has mostly been in the clinical space, and I think a lot of the traditional interventions around goal 3, SDG 3, MDG 3 especially, have been on health system strengthening, workforce, and essential medicines. One might now add universal coverage as a major concern, but increasingly, as the evidence base has been developed for addressing these broader cross-sectoral health and all policies kind of domains, we begin to see the importance of urban planning, of elements of the built environment and natural environment, as well as socioeconomic variables. And the key really is getting these two very large communities or multiple communities really to collaborate and interact. And again, political leadership becomes important, and the clinical community, which has tended to dominate the conversation historically in the health sector, I think increasingly is realizing that they may see a patient in a hospital or in an office, but if they send that patient out to the environment in which they came from, they may not get better. Their asthma may be exacerbated by the living conditions in their homes or the presence of a waste transfer station in their community. So this is a conversation that we're trying to promote in the International Society for Urban Health globally, and I think increasingly at country and city level. So bringing the SDGs and the new urban agenda together to call attention to urban health. Again, the role of health as both an input and an outcome of development is possible. One can think about that when you move away purely from concern about healthcare, the fact that healthy people are critical to a thriving country and city, that decisions are made, as I've said before, across multiple sectors that can influence the conditions in communities that create health, that equity has to be front of mind, and that the political environment and political leadership is a crucial issue. And finally, as we move through the implementation of the SDGs, there is a focus on national urban plans that are reviewed in many of the high-level reviews, that countries are encouraged to develop national urban policies. This obviously the key of decentralization strategies. Every country delegates more or less authority to local governments. And these are factors and abilities to have cities be more of an engine, more of a driver for global health. Governance is an important issue. Government, effective government, working with other partners in business and in the civil society, and looking at the healthy choices in large infrastructure investments. And finally, just a place-based strategy for all of our thinking about health and health improvement. So I'll stop there. Thanks, Greg. This is how to contact us, and we're delighted to talk to anyone outside and after this session.
Excellent. So we've got a few questions for you. So there's one that actually feeds in from the previous one. I think it might be the same person. And they would like to ask how, again, blind, deafblind, partially sighted and disabled people are truly being engaged in ensuring healthy cities, particularly around accessibility and mobility issues.
Yeah, it's very interesting because I think in many ways in the United States, at least, the Americans for Disabilities Act has led the way in terms of certainly modified built environments for this, for really all people. And I think the age-friendly cities model has also built on that platform. When Mayor Bloomberg was leading a lot of the public health change in the city of New York, the platform really was for cities of all ages, and many of our insights from addressing individuals with disabilities really had already created a platform on which to build broader health and all attention to changes, especially in the built environment and the socioeconomic environment.
And we've also got another question about green and blue spaces. So how important is the provision of green and blue spaces within city environments to ensure the health of the inhabitants?
Well, I think we're learning increasingly that green space is a really important factor, not only in people being willing to go out and exercise, but in mental health. And colleagues in Germany and others have really been looking quite directly at the mental health effects of a feeling of control over one's environment, of being able to move outside. And I think one of the reasons why, certainly in this city and many cities, people are being encouraged to exercise. I know in New York City, we're closing 40 miles of streets over the next weekends. The mayor's moving in that direction until the lockdown is over, to provide an opportunity for people to move around, to walk in parks, to with social distancing, of course, at this time, to run along rivers. And there's been a lot of development there. So I think that evidence is very clear on many levels and being really encouraged.
Great. And we've got one final question before we go on to Stefano's presentation. How do you overcome the challenge of the urban poor living near to the urban rich with shared policies? Do you feel that policymakers address this issue enough?
The answer is no, they don't. I think that's been very clear, certainly in the impact of COVID-19 in the United States, and I think globally. The mayor of New York, Mayor de Blasio, has actually done something I think very important from a policy point of view by asking the health department and all the agencies to look at the equity factor in developing indices and developing programs. So for example, New York has indices of distance from parks, the issue of air pollution, looking at relative air pollution rates in different geographic areas, issuing very explicit reports on communities within the boroughs and the distinction between communities like East Harlem or Bed-Stuy and Brooklyn and other entities. So I think this is it's a concern. Obviously, the overall investment is slowly beginning to align, but there's much more work to do. And I think one of the concerns is while the COVID-19 has shown a very distinct light on these disparities, the challenge is in the pressures. Can one maintain a focus on improving equity in the recovery phase and in a way that's sustainable going forward to try to close that gap that was identified by the question?
Thank you very much. That was great. Thanks. Are you okay to unshare your screen and then we'll move on to Stefano's presentation? And hopefully you might get a few followers for ISUH signed up.
Okay, thanks. Thanks very much.
And Stefano, are you able to share your screen? So the next talk and the final talk is from Professor Stefano Capolongo, and he's the section president of the Urban Public section of the European Public Health Association.
Hello to everybody. One moment for share a presentation. One moment, please.
Chi dà di condividere? Allow me to share. Greg, allow me to share.
Please, Greg.
Yes,
okay. It's okay.
Able to now.
Yeah. I think it's here. One moment. No. It's okay or not? The video.
It says your screen sharing, but it doesn't actually have anything on there.
One moment, please. Sorry. One moment, sorry.
Si vede?
It's okay, the video or not? The presentation.
We can see a blue screen, but that's it.
One moment, please. I don't know why, but sorry. It's okay, the video or not at the moment? The presentation?
It's still not. It just says has started screen sharing. Have you ticked the bottom on the left that says about like sharing sound and stuff as well?
I don't know why, but strange. But it's okay, PowerPoint, the format.
At the moment, it's just a blue screen.
Yeah. It's okay.
It doesn't say anything. It's just a blue screen. Should there be some text or image on there?
No.
Ascolta, fagli un altro desktop. Così c'è. Ma così condiviso lo schermo, il desktop.
Sorry,
Are you able to perhaps talk without it if it doesn't work?
Dovrebbe andare adesso. Provi a chiedere.
It's okay or not? No.
It's still not coming through. Perhaps you might be able to talk it without the PowerPoint, maybe, if possible.
I don't know why, because
non si vede.
No. Sorry, I don't know why.
Apologies to those watching, but I suppose some
I'm open, not PowerPoint, but the PDF. Probably it's adesso.
Zoom.
Share is desktop.
Prova a 3D, no?
You have the presentation or not?
It's still not showing up.
Why?
It's strange.
Puoi sceglierlo tu, Andrea?
Sto provando.
Io faccio stop share.
I'm ask help to Andrea, my collaborator.
Greg, can you see my desktop?
You see.
Yes, you can see it.
Okay.
Ok, just... ok, venga qua.
No, fa niente, facete qua. Ok.
Tenga questo. Okay, can you see the first slide, please?
Yes, we can see it now.
Okay, thank you, thank you.
Okay, thank you very much, and sorry for this situation. Thank you very much, Greg, for inviting me. I'm very happy to be here. So the title of my presentation is COVID-29 and the cities from urban health strategies. Ok. Ma è ricordato come se fosse registrato, sto parlando...
perché c'è sotto YouTube.
Okay. So I'm Stefano Capolongo, and my background is architect, and I'm PhD in public health. This is important for understand the approach of my presentation is a designer approach, but I think the architect or in general the designer have a very important key role for define the new challenge, the new strategies for the urban health. So I start my presentation with the very fast theoretical background and current scenario. It's clear today we have 50% of the world's population live in urban areas. And we have the provision in the future in 2015, moreover, 70% of the people live in the urban area. For this reason, I think it's very important today, the topics of urban health, because I want to remember in the city, in the urban context, we have many opportunities, but in the same time, we have many risks for the health. For example, I want to remember the opportunity is the education, the culture in the city. The opportunity is the economic aspect and the services or social accessibility is a very important opportunity, but in the same time, we have many risks for the health, for the population. For example, air pollution, the problem of the noise in the city, the security, but in general, we have the environmental problem. I hope and I think today the big challenge is to live in the city with the same characteristic, with the same opportunity of the extra urbana area. So the relation between public health and urban planning, it's a very historical relation. For example, this map is the map of the city in Paris, where Haussmann, architect Haussmann, in 60 years redraw completely the city. And the topics for redraw the cities is the health aspect, in particular, the green space, the green line, to define the dimension of the street, to define the height of the building, to define the installation for the in the city, for improve the well-being aspect. The same historical approach in the urbanistic approach is, for example, in Barcelona, the map of historical map of Barcelona with the Cerdà, and the neighborhood draw is based for guarantee many illumination and many sun and climate aspect. And this is a very funny presentation, but it's very clear the relation to design aspect and medical aspect. For example, moreover, the architect use the terminology, medical terminology, for describe the city. For example, the arterias is the circulation traffic router in the city. Or for example, when you want to describe the city center of the city, to comparison the city center of the heart of the human body, and the other consideration. I want to remember the origins of the epidemiology start in London with John Snow, when discover one part of the population have a problem of the cholera. And the question is, why only one part of the population in London is sick of the cholera? And discover the problem is the water contamination only in one specific part of the city. And the answer of this problem is the sewer network for London for reduce the cholera epidemics problem. And it's interesting because it's a physical space approach for one very big problem of public health. I want to remember the determinants of health. We have four many categories. 50% of the factors, determinants of health is socioeconomic factors and lifestyle, 20% environmental condition, 20% genetic inheritance, and 10% healthcare services. For the 15% and 20%, I think the designer have a very key rules for control these two very important aspects. And in this presentation, for example, the non-communicable disease represent currently the 86% of the death and the 70% of the disease in charge of Europe region. And I want to remember the sedentary is the first reason of the death. In this graphic, it's very clear underlying socioeconomic, culture, political, and environmental determinants, and in particular globalization, urbanization, population aging, is the first step for the main chronic disease: heart disease, stroke, cancer, chronic respiratory disease, and diabetes. We have many strategies for implementation the health in the city, and for example, Città Sani, Healthy City, or UK Healthy City Network. World Health Organization define very specific definition of the urban health. The urban health is the current configuration of the city, and more generally, urbanization present many risks for public and individual health, but also many opportunities. In fact, if the cities are planned, well organized, and conscious managed, a synergy can be created between institutions, citizens, and professionals able to improve the living condition and the population health status. Another important aspect for understand exactly the urban health approach is the economic aspect. For example, in this study, it's very famous in Italy, is Geppo Costa and Stroshan in Turin city. It's very clear where the expectancy of the life of the people live in the city of the center, it's too much height, and the expectancy of the life of the people live in the periphery area, the expectancy of the life is low. And it's very interesting because the red line is the underground metro for connecting the city center and the periphery. And the underground, I think it's a very important strategy for promote the health, because connecting the city center with the periphery, and it's important for creating the economic aspect, the social aspect, and in particular the inclusion, health inclusion. We have many strategies, many action designed for the healthy place. I go very fast in this part for understand. We have the environmental risk, urban health strategies, health outcome, but it's important to have a specific tool and specific approach, specific design for reduce the risk of the factor. For example, it's very, I go too very fast. For example, for urban health, the green infrastructures are very, very important. One very big, very strategy important is, for example, in Manhattan, New York, to collocation the park in the middle of the Manhattan. I think it's a very important design strategy for urban health, for example. But there are many, many studies for the benefit of green infrastructure in the urban area, for the climate, for the physical activity, for the climate change, for the other question. Another very important example in New York is the High Line to transform the old street for the train in a park, where it's very important in the green area, in the linear park, I input not only the green area, but the green with the activity. This is very important because people go in this part of the city not only for the pedestrian area, but because it's important to have the strong activity. And this very is a mixité, functional mixité. So the other example for the urban health, the other strategy is blue infrastructures or gray infrastructure, is public space. I think it's an important strategies for meet the people, for to promote the social inclusion, And for the physical activity, for example, for the bicycle or the other important activity in the public space. Or other important aspect is the biodiversity protection, or the meteorological water management, public transport. And here we have a video very interesting for the experience in Barcelona, because transform the block of Barcelona in super block. And I look very fast this video. Quanto tempo ho? Non va l'audio? Qua si sente.
They call them superilles.
Superillas?
Sí, superilles.
That translates to superblocks. It's this urban design concept intended to minimize the presence of cars in city centers. The word superblock has been used before to
Okay, I think we have the problem with the audio, and I go the next step of my presentation. But this is a very interesting experience for the superblock model, because Barcelona transformed the neighbor, the small neighbor, in the big neighbor, and go to implementation, for example, the pedestrian area, and reduce the traffic in the middle of the street, and to transport the fast traffic outside the neighbor, and go to put inside in the local street many activity for implementation, the physical activity, the cohesion, the social cohesion, and the mixity, functional mixity. This is very important, this study, because in the same time we have one very important epidemiological study for understand the expectancy of the life in the future after these design strategies. Pedestrian and cycling paths is very important for the urban health, and social mixity. For example, the playground is a very important strategies for the health, not for promote the physical activity, but for the social cohesion, social aspect. And this is very famous example in Copenhagen, to transform the roof of the parking in sport area. And I go very fast. Okay, I want to present the last part of my presentation, the new strategies to the pandemic challenge, COVID and the city, because I think today we have a very big challenge, is to rethink in general the design, the house, the hospital, but the big challenge, I think, is to rethink the city. We have to publish recently the paper in Acta Biomedica. The title is COVID-29 and the Cities, from Urban Health Strategies to the Pandemic Challenge. And we have to define a decalogue of public health opportunities with the other colleague. In particular, the decalogue of public health opportunities, we have 5 action in immediately action and 5 action in medium long-term action. So very fast, the first action is in the decalogue for the urban health promote is the program, the flexibility of the city schedule. What the flexibility of the city schedule? For example, is the differential access time to school, university, but in general to public building to avoid gathering in the peak hours, provide vitality of the neighbors during most of the day. For example, at the least 20-hour days. Spread the people trips over more hours and possibility making Saturday and Sunday work day. This is the important, I think, to rethink the hour of the city. So the other aspect in action immediately in the decalogue is plan a smart and sustainable mobility network and to promote activity transport choice, design, realize something temporary like emergency cycle network and pedestrian urban area. In Milano, we have at the moment the very important innovative strategies. In general, these strategies want to improving the walkable environmental. Here you have one example. This is the actual situation, and this is the provision to transform the street, the main street of the city, in a pedestrian and cycle way, very, very fast to reduce the traffic. And but this strategy, I think it's important not only for the COVID problem, but it's important for the future of the city. For example, the environmental or climate change. And in these figures, it's interesting. This study is a systematic study because it's a plan, a smart and sustainable mobility network. In this map, it's possible to identify the street where the platform it's okay for the pedestrian. Red is not very good situation for the pedestrian because the dimension of the platform is 2 meters and 15. The orange is and yellow is situation is dangerous. In the green is safety, and in the blue line is a perfect situation. The perfect situation is minimum 4 meters of the platform for the pedestrian because is important for walk 2 persons in one part of the platform and other 2 persons in the other part, and we have 1 meter is the minimum for the distance of the pandemic risk. And here in this map is possible, for example, to understand in Milano, we have 50% of the platform is a very answerful risk, and we have only 17% of the platform is the ideal situation. And this system, this aspect, I think is not only in Italy, but in general in the Europe city. In the decalogue, the other important aspect is to define a neighbor services plan. And we have a very interesting experience in Paris. The name of this experience is Ville du Quart d'Heure, where it's for the people, it's possible the accessibility to the service maximum distance of the 50 minutes from their home. And this is important for revitalization of the neighbor, for the ecological transformation of the city. And for example, in this image, you have a linear park, pedestrian street, but in the same time, it's interesting because it's possible to discover other space in the city. And for example, the roof of the building. Or the other interesting experience is in Glasgow, for where in this map, it's interesting to discover the green, livable and attractive area in the underground space of the city, because it's important to identify not only the activity in the building, but it's important exactly the activity in the main floor in front of the street. The other important aspect for the urban health in COVID, but not only for the COVID, is a problem, is a world problem, pandemic problem today. But it's important, the urban health, to consider the sanitary emergency in the future, not only today, because the history of the pandemic situation, we have many pandemic situation, SARS or the other, you remember other pandemic. It's important the city prevenues and program the activity for reduce the risk in the city. For example, develop and digitalization the urban context, promoting the smart communities. It's very important for use of IoT systems, permit a systematic data collection action, for example, detecting and evaluation the presence of different atmospheric agents, including outdoor air pollution, sound pressures, temperature, humidity, and the wind speed. Rethink the accessibility to the place of the culture and tourism. This is a very important social and economic problem in the Europe, because the place of culture and the tourism, it's very, very important to revitalization of this aspect. With the limitation of the access will be the rule, the number of subjects to be allowed in every, to say, 50 minutes. The digitalization can play a key role. It's important to rethink the flexibility of domestic living space in order to realize isolation room, to ensure adaptive privacy for the study, agile work, relaxing moment, and for children's play, but also large space to guarantee the mobility of wheelchairs or other support for elderly assistance. In this period, it's very important, I think, the external space of the house. It's very important, the cross ventilation, natural ventilation of the domestic space. And it's important to consideration a co-housing situation, the presence of easily adapted space to expand residential capacity and maintaining physical distances like semi-basement. I'm concluding with it's important to rethink the building typology, for example, with the like a terrace or the court of the building, fostering the presence of semi-private or collective space. And one example in Milano is vertical forest, for example. And then I want to conclude my presentation with the other 3 points is renovate the basic care service network. It's important to micro scale and macro scale, urban scale and neighbor scale, And it will be important to promote a network of interactive facilities, in particular regarding the most socially disadvantaged city context. And in the micro scale, the neighbor scale, it will be important to improve the discourses regarding the localization and times of primary care services. And sorry, and the last is important to integrate the existing environmental emergencies plan with tools prepared for the health emergency. Usually we have the tool for the health emergencies, for example, for the seismic problem or the catastrophic problem in the land. But today it's important to define the health plan, the health tool for the prevention of the pandemic problem. And I think it's very important, the multidisciplinary approach, the interdisciplinary approach, and I think it's improved stakeholder knowledge of the factors affecting public health in the city, and the synergy and the awareness of all the technical and medical professionals involved in the urban planning process is crucial. For this reason, we want to, my research group with the Healthy City Institute in Italy, I want to propose the new figures in Healthy City Manager, and we have to define the core CV for the new competence to manage urban health, Healthy City Manager core curriculum. This is the objectives, and in particular, I want to underline healthy lifestyle, urban transport, and urban and architectural planning. This is a very big challenge, because I want to remember the health is not only a medical approach, but the health today, the approach is a social approach. And in general, I want to remember the expectancy of the life is in the city is more over, and the urban paradox is more compactness, better public health. As cities get more and more compact, they become more walkable. In dense residential area, they are better designed and more attractive destination. We are less dependent on our cars and use public transport more. And the last figures is the Milano map. It's very recently, and is interesting because is in the middle of the center. The case of the COVID is very, very low. Where it's low, the pandemic COVID. Where the economic status is high. In the periphery of the city, the infection are very, very high. Probably is the economic aspect, but in the same time, the other problem is the north neighbor are more connected to the industrial area and to the infrastructures, airports, train station, and highway. Okay, thank you very much for your attention, and I'm here for your question.
Yeah, thank you very much for that. You went through quite a lot of detail there. So a couple of questions that have come through before we wrap up today. One person's tweeted to ask, as countries are moving out of the lockdown, And what research has been done to investigate safe approaches to public transport use? I know you discussed a little bit about that there, but if you could just elaborate more on what research has been there to protect users and reduce the risk of COVID-19 spread.
But the public transport, I think it's is a crucial aspect of the city. And with the COVID, it's changed completely the approach, because we have the limited number is inside the public transport. But and for this reason, in this particular moment, we go to implementation the pedestrian area and the cyclable way. But I think in general, in the future, the public transport, it's a very important strategy. But the public transport, I think, is not only the underground or the bus, but for example, the car sharing or the bike sharing, this is public transport. And for the prevention of the COVID, I think it's very, very important. But in general, the public health is an occasion for reduce the sedentary in general.
Okay, and then there's one final question before we wrap up for the day. In your opinion, how important is the quality of the green space as opposed to just the availability of the green space?
But the green space, I think it's very, very important in the city for the quality of the air pollution, but not only for the quality air pollution, but for example, the social problem, and in particular for reduce the temperature in the city. It's the problem of the heat. And the green, it's important for the mental health. This is very important, because I want to remember the state of the health is physical and social and mental health. We have many studies in evidence-based study, evidence-based design study. In particular, I want to remember the study of the importance of the green. Sorry, don't remember the name, but one moment. Ulrich, yeah. And where to demonstrate the importance of the green for the health. For example, one room of the hospital with the window where view the green, you have the capacity to reduce the time in the hospital. The green is important not only for use the green, but it's important to view the green. This is very, very important for the well-being in general. And then the other aspect for the green is to identification the biodiversity, for example, for the biodiversity in general.
Thank you very much. That's brought it all to a nice little close. I'd like to thank Stefano and all of the other guest speakers today. I'm not sure how many of them have managed to stay on for the whole of it. And thanks to the audience. And we've got some more presentations tomorrow, if you are able to join us. We have Dawn Dowding from the University of Manchester. She'll be speaking about infection prevention and control behaviours amongst care home nurses. And that'll be followed by Professor Anise Eshmael, who will be talking about the implications of COVID-19 on primary care. And then we've got Elena Petalos from the University of Crete, and she'll be discussing health technology assessments. And we'll end with Professor Michelle Briggs, who will be talking about commemorating Florence Nightingale in the digital age. So we hope that you've enjoyed today's talks, and we hope to see you tomorrow. Thanks.